Welcome back. Our next section has got a trio of three doctors of physical therapy to expand into areas of frailty. And I mentioned also Dr. Monica McHenry, who's working with the group and some of the frailty issues, so a couple folks are involved here. Aging in place, more than half of older U.S. Medicare beneficiaries can be classified as pre-frail or frail, so the numbers are big. The goal of the group presenting is to enhance your knowledge in terms of frailty, how it has an impact on aging, and some ideas of activity, exercise, and physical therapy that you use to prevent and treat frailty. So I'm going to introduce all three speakers up front. They're going to kind of flow from one to another. So the first speaker, Dr. Janet Billat, is Assistant Professor of Physical Therapy in the Department of Physical Therapy at New York Medical College. She's a research scholar for the Center for Long-Term Care. Her research interests include access, barriers, outcomes of rehabilitation for older adults, identification of important factors impacting utilization of physical therapy services. She has some target articles published in that domain. And understanding the value of physical therapy for society and individuals. She received her DRPH in healthcare policy management from New York Medical College, and both her master's in physical therapy and doctorate degree from Simmons College in Boston. She's a board-certified clinical specialist in orthopedic physical therapy and chair of the Payment and Policy Committee of the Health Policy Administration section of the American Physical Therapy Association. Kind of a broad background there. The second speaker is Dr. Sonia Nikki Goronsky, Assistant Professor of Physical Therapy as well. She received her bachelor's degree in physical therapy from Quinnipiac College in Connecticut, and a doctorate of physical therapy degree from Dominican College in New Jersey. Now she's in New York, so she's kind of across the way. Right? Actually, Dominican is New York. Two states, I would. She's board certified, a clinical specialist in geriatric physical therapy, and a certified exercise expert for aging adults. Over 23 years of physical therapy experience in a variety of settings, acute care, subacute, outpatient. She's a member of the American Physical Therapy Academy of Geriatrics. She's currently involved in a research project examining frailty and falls risk in older adults, collaborating with Dr. Monica McHenry in speech-language pathology. We're trying to identify some interprofessional markers for frailty, kind of putting together a team that way, which is really great. She's a co-director of clinical education for our department and teaches professional practice 1 and geriatric content. And the third speaker, not the least, is Dr. Gail Lavender. She's also a co-director of clinical education in the program. Bachelor of Science degree in physical therapy from Old Dominion University in 1982, and doctorate degree in motor learning and adult higher education from Teachers College, Columbia University. Again, over 25 years of experience in a variety of settings, pediatrics, acute care, subacute. She's published work in recovery of function of children with cerebral palsy and issues of spirituality in physical therapy. Also board certified in geriatric physical therapy and a member of the Academy of Geriatrics. Along with her clinical education responsibilities, she teaches coursework in cultural competency for the program and clinical decision-making for complex patients. So, nice group of people. I'll introduce first Dr. Dwight to start us off.
Thank you. Good afternoon, everyone. I'm so lucky to be part of such a wonderful team with Gail Lavender and Nikki Goronsky. It's been such a wonderful learning opportunity, so thank you, and thank you for the opportunity.
Get closer to the microphone, please.
Okay. Okay. So I just was giving kudos, even more kudos to my team members for this, so it's been a wonderful experience. We wanted to talk with you today about frailty, kind of in the context of aging in place. And some of you might be wondering, well, why is it critical to consider frailty when discussing aging in place? And it's really critical because frail older adults have increased risk of poor balance, poor quality of life, falls, not driving, disability. They have increased risk of hospitalization and nursing home admissions as well as mortality. And as you can imagine, each of these really would put up a barrier to aging in place. So what is frailty? Frailty basically is a physical condition. It's characterized by limited physiologic reserves that place the person in increased vulnerability to negative health-related outcomes. And frailty really exists on a spectrum. So it can go from as much as no frailty at all, which some people talk about as being robust, to being frail, and there's a middle ground called pre-frail. It tends not to be linked to one specific health condition, believe it or not, or even a specific number of conditions, but the more health conditions a person has, the more likely they are to become frail. Operationally, frailty can be defined in multiple ways by public health researchers as well as clinicians, and as you can imagine, this kind of muddies the waters a little bit when you start to have a discussion about what are the important issues we need to consider. Probably the most common or most frequently used definition for frailty by public health researchers uses the frailty phenotype. And this was described by Fried et al. And it consists of 5 criteria. The criteria include exhaustion. And to be positive on exhaustion, a person has to report fatigue with normal activities of daily living. Weight loss. To be positive on weight loss, it's a loss of 10 or more pounds in the past year. Low physical activity, and that's based upon how much activity per week does someone engage in, how does that compare to their age-matched peers. Weakness, muscle weakness, someone would be positive if they're significantly less strong than their age-matched peers, and typically that's measured through grip strength, because grip is pretty functional for a lot of activities. And then also slowness. Slowness is the 5th, and that's walking speed. So if someone walks significantly more slowly than their age-matched peers, that would be positive for that. And so in terms of the stages of frailty, if you meet none of those criteria, you would be categorized as robust. If you meet 1 or 2, that would place you into the pre-frail category, and 3 or more marks you as frail. Okay, so how prevalent is frailty among older adults in the United States? So Vandine, Roche et al. You try to answer this question using the National Health and Aging Trends Study, which is a population-based study looking at Medicare beneficiaries in the United States. So that really captures by far the majority of older adults in the U.S. And what they found, okay, good. So they found that amongst community dwellers, about 14.5% are frail, but 45.2% are pre-frail, which is definitely more than the proportion who are robust in that category. In terms of gender, females tend to have a greater proportion of frail and pre-frail persons within compared to males. In terms of income quartiles, people that are part of the lowest income quartile have a greater proportion of frail and pre-frail folks by far compared to the highest income quartile. In terms of age, as you might expect, the older we become, the smaller proportion of robust adults there are in that age cohort, and the larger proportion of frail adults there are in that age cohort. And in terms of race and ethnicity, to be Black and Hispanic, there's a higher proportion of folks in the frail and pre-frail categories compared to robust and relative to other races and ethnicities. Okay, so what places one at risk for becoming frail? Fang et al. Did a systematic review of longitudinal studies that looked at risks over time and what best predicts becoming frail. So they identified socio-demographic factors, most of which I just talked about. They found physical factors are a component. Allostatic load. So allostatic load refers to stress over time that someone experiences, kind of negative stress. And the greater load, the greater chance that someone will become frailty at a later point in time. The more falls that they've had, if they've had falls in the previous 12 months, the greater number of falls they've had, the more likely to become frail. If their arms and legs don't function as well, if they require assistance with their activities of daily living, that also puts them at a greater risk of becoming frail. There are some biologic markers as well, too, that seem to predict frailty. White blood cell count, monocyte count, lymphocyte count, which tend to kind of characterize more inflammatory states. They were not able to find clear links between lifestyle factors, including diet, smoking, and alcohol. The research kind of goes both ways. There's no clear link. And psychological factors, including depression and impaired cognitive function, also put one at a greater risk for becoming frail. And in their studies, they looked at adults who were 60 and over, and their time period of follow-up for this systematic review was like 3 to 10 years. So it really was longitudinal over time, kind of looking at this older adult cohort. There are caregiver impacts for people who are frail. And so for spouses or children who provide caregiving to their loved one for any amount of caregiving, about 90% of spouses provide assistance 7 days per week, and about 70% of children provide assistance 7 days per week. Of the spouses who provide any level of support, about 8% also have paid employment. For the children who provide any type of support, about 50% also have paid employment. Now, for the spouse and children who are primary caregivers for their loved one, and the spouse and child also have outside paid employment, quite a large proportion, significant proportion of each of those have needed to rearrange their work schedule, work fewer hours, or took time off without pay. So that caregiving burden balance with that employment is burdensome for that person, which I think is not uncommon when someone is a primary caregiver of their loved ones. And then frailty also has other societal impacts. Frail includes frail older adults use more hospital services at greater cost than robust adults. And frail older adults account for 44% of preventable U.S. Medicare spending. And how preventable Medicare spending is defined by the Agency for Healthcare Research and Quality, AHRQ, and it's money that's spent on inpatient care for health conditions that are actually can be very well managed on an outpatient basis, so shouldn't necessitate that level of inpatient care. So Dr. Gronsky is going to talk about normal aging and how that can intersect with frailty.
Way down. So this is by no means an exhaustive list for normal aging. But I put these on this slide because they pretty much tie in with what we're talking about when we talk about Freed's criteria. Because when we're talking about Freed, we're talking about exhaustion, weakness, slowness, and decreased physical activity. So as one ages, there is a decrease in lean muscle mass, which is sarcopenia. We also see that there's a 10% decrease in muscle strength, and there's a decrease in the size of fast twitch fibers versus slow twitch fibers. And the significance of that is that we need those fast twitch fibers to react. So if somebody wants to get up off of their chair quickly, they would require those fast twitch fibers. Okay? There's also a decrease in bone mass, which affects postural changes, and decreased elasticity of tissues, which can cause a loss of range of motion, and it could also cause painful motion. So with the cardiovascular system, there's a decrease in maximum oxygen consumption, decreased cardiac output, decreased capillary density, decreased speed of red blood cell production, and an increase in peripheral vascular resistance. So this all decreases blood flow to the muscles, and it decreases endurance. There's also a decrease in vital capacity and elastic recoil of the lungs, and increased residual volume in the lungs. These folks will have more shortness of breath, and their endurance is impacted. So this slide shows the slippery slope of aging. Before I get into that, I do want to also note that there's a commonality between the normal changes of aging and what we see in Freed's criteria, right? So you might think, well, how does one distinguish normal aging from frailty? And the rate and the extent of the physiological changes vary among individuals, okay? So the rate and change of normal aging is varied. The slippery slope of aging has vigor on the x-axis and age on the y-axis. So basically, what Schwartz was saying in his paper is that as you age, you go through the different categories from fun to functional, frail, and then eventually failure. But it's not exactly linear. So if you notice at the top of the curve, there's a bit of a plateau, and also at the bottom of the curve, there's a bit of a plateau. And this represents that physiological reserve that Dr. Bob was talking about. So when somebody's fun, they have more physiological reserve. So if that individual had an incident that put them in the hospital or on bed rest, they would be more apt to stay in that fun category. We can get them rehab fairly quickly. But when one is in failure and we start to exercise them there, it's going to be a lot harder to get them up that curve. It's not impossible for somebody to go from frail to functional. They are able to go up that slope with exercise and with intervention. And that's where we want to see individuals on that slope. We want to see people who are functional or pre-frail, if you will, and those folks that are at risk for frailty. We want individuals, as Ms. Locke said, if they're on the floor, we want them to be able to get up. And we want them to be able to punch back, right? So as physical therapists, we're big on function and we're big on participation, and that's our goal. So again, this slide shows fun, functional, frail. And Janet spoke about robust, pre-frail, and frail. So for the purposes of this slide, we'll call fun robust, and that's unrestricted participation in life, right? An improved quality of life, a wonderful quality of life. These folks are working, they're enjoying their hobbies, they're exercising, they're involved, they're independent with all of their activities of daily living. But when you look at someone who's functional, there's actually a range, right? Somebody can be on the high end of functional or on the low end of functional. So when they're functional, there is some restriction in the leisure activities due to decreased physiological capacity, but they're able to perform their activities of daily living. And then when one is frail, they may have difficulty with their basic activities of daily living, and these folks sometimes will need assistance with work and household activities. And they have a limited participation in leisure activities. They're less apt to go out to do activities just for fun. So this study by Shumway Cook, they looked at what is really required for an adult to age in place. What type of requirements are required for them to function optimally in the community. And the first thing that we see is to be able to walk 1,200 feet. And I don't know how many people here work in the hospital and use FIM scores or the new GG codes or CARE tool. Anyone familiar with that? So these are measures that we use in the hospital and the rehab setting. And in the hospital rehab setting, their benchmark for community distance is 150 feet. Okay? So Shumway Cook is saying, no, they need to be able to walk 1,000 feet. And I would argue that this is true and sometimes more. You know, we're doing our shopping in big grocery stores, big box stores. They're going from a parked car out into the store. So this is necessary. Gait speed, 1.2 meters per second. So I do a little bit of research, and the average avenue to cross in New York City will give you 45 seconds to cross about 68 meters. That's 1.5 meters per second squared. Okay? They need to carry packages, 6.7 pounds. A gallon of milk is 8 pounds. And they need to be able to walk, not just on this nice level carpet, they need to be able to walk in grass, on gravel. They need to be able to pick up something if they drop it off the floor. They need to be able to reach. They need to be able to look. They need to be able to do 2 tasks at one time. So when someone comes into physical therapy, we have a few performance-based measurements that we look at. And these also are related to 3 criteria. We look at the TUG, which is the timed up and go. And we time somebody from getting up from a chair, walking 10 feet, turning around and coming back. That's functional activity, that's looking at their balance, and that's looking at their gait. If they're in the fun category, that's less than 8 seconds. If they're frail, it can take them up to 20 seconds to do that activity. We look at gait speed. We look at the 6-minute walk test, which will show us someone's endurance, and that's how far that they walk in 6 minutes, and looking at their vital signs. 30-second chair rise test looks at lower extremity strength, Berg balance, and the 4-square step test is something that we do where they're stepping over canes, they're going forward, sideways, backwards. They can use an assistive device or not, but we're also timing them in that activity, and that'll tell us if they have the ability to go over obstacles and how their balance looks. So I've highlighted here some of these performance-based outcome measures are also tell us if somebody is at risk for falling. Okay, and that's really important because falls brings people to the hospital, and the hospital brings people to, leads people to bed rest, and bed rest leads to physiological decline. Okay, and then that could lead to frailty. So the cutoff for a tug that would lead to a fall would be 12 seconds. So you can see that some of these folks that are functional or pre-frail, if you will, can easily go down that slippery slope to frail. So it's important for us to identify them so that they don't go down that slippery slope and we maintain their activity and improve their physiological reserve. But frailty is distinct from disability. They do have different care needs than disability. Frail elderlies are more vulnerable for adverse health outcomes, but we can help to prevent that. Unfortunately for us, as physical therapists, we see them usually when they've had a disability. We see them in the hospital, we see them in the rehab center, but wouldn't it be great if we could see them prior to having a disability and we can help prevent this? Thank you.
Good afternoon. I'm going to talk a little bit about prevention and how we might go forward in addressing frailty in the older adult. So in addition to what Dr. Gawat talked about earlier, there's a list of other characteristics that we might observe in the frail adult. We don't always recognize some of these characteristics, which are not uncommon in the frail elderly. All of these can lead to reduced reverse capacity, and that occurs with the normal aging process. So we as physical therapists have the skills and the knowledge of aging and exercise that is backed by the evidence to improve strength, increase activity, and improve gait and balance. We as physical therapists can also design relevant and challenging exercise programs to prevent and reverse frailty. And by addressing these concerns, we are fulfilling the vision put forth by the American Physical Therapy Association, transforming society by optimizing movement to improve the human experience. So I just want to go over a few of the exercise guidelines. These are things that if you want to improve your physical conditioning, whether you're frail or robust or pre-frail or in none of those categories, you would want to take into account these 4 domains. The guidelines I'm going to tell you about are for frailty. However, you would just be able to differ some of those guidelines if you're robust or pre-frail, and all of the domains should really be addressed in an exercise program to improve overall function. So for aerobic training, we're looking at the large muscle groups, rowing, cycling. You might want to work, if you are in the frail category, you'd be working at 40 to 70% of your maximum heart rate, as opposed to 60 to 80% if you were in the robust category of maximum heart rate. You want to work at 30 minutes. This can be done throughout the day, 3 to 5 times a week, and you would progress to 60 minutes a week. Again, these are frail guidelines. Resistance training, again, weights, therabands, machines. We look more at how hard one is working, so we use the Borg scale, and we would look for something between 12 and 13, which classifies the ability to do those activities as somewhat hard. You'd want to do one set of 8 to 10 reps for each exercise. You want to vary the exercises. And that would happen less than 60 minutes of a time, 2 to 3 times a week, again, just like any one of us. And then if you want to progress the program, you would increase their resistance or increase repetitions. For flexibility training, stretching programs, yoga, chair yoga would be conducive to flexibility. The intensity is really, you don't want to stretch beyond what's comfortable for you. 3 to 7 times a week, 10 to 15 minutes a day. You would progress by making longer holds or increasing the repetitions. Functional training, one could look at Tai Chi programs, obstacle course programs, or a number of programs out there. You would do what you're able to do, how much you can tolerate, 2 to 3 times a week, 20 to 30 minutes a day, and then once you've learned those skills, you might increase your own, challenge yourself to increase your performance. So choosing widely is a multidisciplinary campaign that is to increase public awareness of health information. Clinicians and individuals trained to run exercise programs for the older adult need to choose wisely by remembering not to underdose. So there's a lot of underdosing out there in terms of exercise. I know I work in the clinic in the subacute setting, and my colleagues, I watch them do 10 sets, 3 sets of 10, 3 sets of 10, 3 sets of 10, 3 sets. So not really taking into account what folks can really do. So there's a need to really adjust frequency, intensity, and duration based on what the goals are. There's a couple studies here, just quickly, these are the results. The first one by Fiatarone. They were looking at 10 institutionalized volunteers, aged 89, over 8-week period of time. Training starting at 50% of 1 RM and increasing to 80% after 2 weeks. They found, again, high resistance weight training. And so there were significant gains in muscle strength, muscle hypertrophy, functional mobility among elderly individuals. In the second study by Sullivan, this was looking at elderly hospitalized individuals after an acute illness, and 19 subjects, 82 years old was the average. 13 were ambulatory, 6 were non-ambulatory, and at the end of the study, strength improved 20%, 17 subjects, improved sit-to-stand, improved gait speed, and then the notable thing here is that 4 of the 6 non-ambulatory folks progressed to ambulatory, which is a significant, which is notable in terms of reversing frailty from Braille to pre-Braille. Some additional studies looking at community-dwelling adults. These are 2 studies by Binder et al. In 2002, 2004. The first group was 115 subjects, the mean age was 83, divided into an exercise training group and a home exercise program. They also kept dietary records at 3 days for a baseline, and then followed up at 3 months, and then again at 6 months and 9 months. So you can see the results here. The exercise training group, significant improvement in the modified physical performance test, chair rise test, oxygen consumption, and also increased their scores on the functional scale questionnaire, which is looking at quality of life. Second study looked at 90 subjects, and this was really an outpatient, looking at individuals who were post-ops hip fractures within 16 weeks, participated in an outpatient rehabilitation program as opposed to home exercise program, divided into 2 groups, and they were followed for 9 months at 3-month intervals, and again, this group improved in their modified physical performance test, more so than the control group. Mean changes in the independent ADL scores. They had increases in muscle strength, walking speed, balance, and perceived health as measured by the SF-36. And then here's one more study looking at institutional dwelling adults. Again, these are 37 pre-frail, frail elderly folks, mean age of 76. Basically, this was done by Ferreira et al. It was a randomized controlled study out of Brazil. And again, they were seen for 40 minutes, 3 times a week for 12 weeks. Improvements were seen in strength, speed, agility, also some biochemical markers. And the exercise group, what is of note here, is that 34% of the people who were rated or fell into the frail category were returned to pre-frail. So how do we prevent frailty? I think one of the biggest things that we're facing as a healthcare profession or as a society is really the challenges of how do we identify these folks that are frail. There's a study done that was looking at physical therapists and occupational therapists and how they really sort of rated frailty, and they looked at freeze criteria versus their sort of a personal opinion, looking at ADLs, looking at function. And what they concluded was that effective and timely identification of frailty underpins the success of prescribed interventions aimed at reversing or slowing progression of this syndrome. Therapists need to be clear on their classification criteria, and these are tests and measures to assess, there are tests and measures to assess the older adult's capacity. However, those in the community, including those also in our profession where we need to do a little better job, in how we can classify these people rather than looking at their personal environment. And then hot off the press, last evening I was reading my journal of the Geriatric Physical Therapy Association. There's a Swedish study just published using the FRESH screening tool, looking at hospitalized frail individuals, screening them for their physical ability. And the conclusion from the study was that they really, this was done by the physicians who were administering the tool, and the instrument really should be useful in evaluating physical fitness in the hospitalized frail elderly, and this may facilitate realistic and individualized rehabilitation programs early on to prevent frailty and prevent further institutionalization. So really the emphasis here is on early identification. So Medicare doesn't really pay us to treat the frail people. They don't really, there's not dollars spent there. However, Medicare does have a program called Silver Sneakers. And that is a program that is free to those recipients and offers different programs for them to be engaged in. Another way to prevent frailty would be trying to be a spokesperson for how we manage folks that are non-weight-bearing after fractures, people that are on bed rest, also folks that have wounds and how they manage to stay in bed longer than they need to, how we might be able to make them more active as possible. And then there's also programming available out there. And this is a list of programs that are available, group programs, in-home programs that you can do, fall prevention programs, both as a group and individual intervention. These will be listed on our resource page. And then screening. This is where I think we need to do a little bit better job. As physical therapists, this screen on the left, we would be looking at some of these characteristics as opposed to what primary care folks are doing. They're using the free criteria scale, which is fine. But again, I think for everyone out there, we need just to be doing more and more screening. So community education, how we can sort of outreach to folks. We need to do a better job of getting in touch with healthcare providers, support groups that have support types of programs, but also how we might say there are some exercise programs out there. There might be better advertising in newspapers. AARP is a wonderful organization that has a lot of information on a lot of things, including programs. And then the more use and education of social media. So in summary, I'd like to say that there's a need for more rigorous screening by the healthcare providers, that we need as a society to become more knowledgeable about interventions to prevent the onset and adverse outcomes that befall the aging population, and that frailty does affect outcomes and it is preventable. Our goal in this whole symposium, colloquium, is that we would like to ensure successful aging and aging in place. Thank you.
Thank you for the team. Because of the time the afternoon, we're going to continue on to our next speaker. I would encourage you to ask questions of the three speakers at break time. We'll take another break after the next speaker. I apologize for not getting any questions here, but we want to make sure we keep on time for the afternoon, so we're going to kind of move on at this point in time. Next topic is nutrition and aging, meeting the challenge and needs of seniors. Karen Kapinski will be our speaker. She's currently the Director of Clinical Nutrition at New York Presbyterian Brooklyn Methodist Hospital. With over 20 years of leadership roles in New York City hospitals, she's a frequent lecturer on medical nutrition therapy, most notably the identification of protein calorie malnutrition in the hospitalized patient. She has worked with clients in private practice, emphasizing an integrated approach to health, focusing on weight management and postnatal nutrition. She holds a Master of Public Health from New York University and is a member of the Academy of Nutrition and Dietetics and the Greater New York Dietetic Association. Karen, come and join us.
It's really such a pleasure to be invited today to talk about a topic that I think is so important, and that is nutrition and aging. Some of you out there in the audience might know that aging presents some challenges to maintaining health. And I'm here to talk to you about how the crucial role that nutrition plays in aging, and also about some of the common challenges that happen as we age that might interfere with our ability to take in adequate nutrition. So let's see. So for anybody who's wondering whether nutrition matters, I think I was invited here to explain to you why nutrition matters, and I'm happy to do that. According to the USDA, half of all adults, and this isn't half of older adults, this is younger adults as well, have one or more preventable chronic conditions, and many of these are impacted by diet and physical activity patterns. So nutrition really does matter. It helps to delay or reduce the onset of chronic disease. It makes us heal faster. It makes our wounds heal quicker. It decreases the risk of falling. And ultimately, we're able to maintain functional capacity because the goal at the end of the day is really for older adults to live independently longer. One of the changes that happens as we get older is we have body composition changes. And if there's anyone in the audience past the age of 40, you probably already are aware of this. We start to see a decrease in our lean body mass. At 25, we pretty much have peak lean body mass, and it's pretty easy to maintain that without doing anything too strenuous. But when we reach the age of about 40, we start to see an 8% loss in lean body mass per decade. That accelerates when we reach the age of 70. And one of the reasons for this is that as we get older, we have declining levels of hormones in our body, most notably growth factor and testosterone. So that really doesn't help us to maintain lean body mass. We might see some increased cytokine activity, which actually promotes the breakdown of muscle mass. And then there's this thing called anabolic resistance. So our muscles are less able to absorb the amino acids that are broken down from the protein in our body. So we're not able to build muscle mass because of that, and we're also not able to maintain the muscle that we do have. And then as we get older, some of us are less physically active, and of course physical activity plays a great role in preserving lean body mass and muscle. This is all quite unfortunate because one of the greatest threats to living independently is loss of lean body mass. So we'll be talking a little bit about what we can do to prevent that. And I think the physical therapist covered part of that already, so thank you. The other thing that happens as we lose lean body mass, some of you might have noticed that you start to increase fat mass. And that in and of itself isn't a horrible thing if it's well distributed, a little in the thighs, a little in the butt. But unfortunately, most of it goes right to the middle and it accumulates intra-abdominally. And that's where a lot of your major internal organs are. So that puts you at risk, or puts people at risk for increased incidence of chronic diseases like cardiovascular disease, metabolic syndrome, diabetes. So we really want to try to use diet and exercise to prevent that from happening, but it is possible that they could be prevented. The other thing, so we have this shift, so we're losing muscle mass, which is really metabolically active, and we're gaining fat mass, which is not metabolically active. So we start to see a decrease in basal metabolic needs, and people start to just need less food. So what are some other challenges that happen as we get older? So our body composition is changing. And as we get older, our GI tract changes as well. Our GI tract is a muscle. And we might start to see some loss in esophageal motility, which could result in dysphagia. The good news is, for the most part, aging doesn't affect esophageal motility that much. But if somebody is really having significant issues with swallowing, it's probably a sign that there's something pathological happening at that point. So it certainly would warrant some further evaluation. Dysphagia is a problem because if you can't swallow, or if you're scared to swallow, you're going to consume less nutrients. Something that happens a lot more often is delayed gastric emptying, and that can happen as a result of aging. That's a problem because when you sit down to a big meal, you're going to be satiated a lot more quickly, and that's going to impact your appetite, and it's going to impact the amount of food that you're able and willing to eat. So as a nutritionist, there's a few things that we can do about this. Delayed gastric emptying happens more with big meals, so we would recommend smaller, more frequent meals throughout the day just to keep the nutrition up. Constipation is probably, if you work with older patients, is probably one of the most common GI complaints. It can be due to reduced colonic motility, but it's more likely due to poor diet, lack of exercise, not enough fiber in the diet, not enough fluid. Also, there are a lot of medications that impact this. So whenever possible, we really want to treat constipation nutritionally or increase exercise. Because what happens is, we end up giving people laxatives. And laxatives actually have the effect of promoting malabsorption of some nutrients. So now we have a population that's already not able to eat as much or absorb as much nutrients as efficiently, and then we give them a laxative that further creates issues for them. So we really want to deal with this in a non-medical way if we can. The incidence of atrophic gastritis increases as we get older. And what happens here is that's an inflammation of the stomach lining. So what happens is we start to secrete less gastric acid. The acid in our stomach environment goes down, and we're less able to absorb many nutrients, many vitamins and minerals, specifically iron, calcium, a lot of the B vitamins. So it becomes a challenge to to absorb those nutrients. Sensory changes, taste and smell. A diminishment in either one of these is going to impact intake. So it's not just taste, it's also smell. The good news is loss of taste is pretty uncommon. We have a lot of redundancy in the cranial nerves that service the taste buds, so we rarely lose significant loss of taste. But what is much more common is that we have taste changes. And these taste changes, unfortunately, don't make the food taste better. They usually make it taste worse and more bitter. So that can decrease somebody's appetite and PO intake. A nutritionist can work with people to help them season foods appropriately with herbs and spices. And what we really want to do is not encourage people to dump salt on their food, because as we get older, we sometimes can't tolerate salt because of chronic diseases that we might have. Smell, believe it or not, has a lot to do with PO intake. And loss of smell is actually commonly associated with aging. 60 to 80%, I think, of people over the age of 80 do have some significant loss of smell. The aroma of food stimulates appetite. So if you can't smell food, you're not going to want it. You're not going to have a desire to eat it as well. So what a nutritionist can do is sort of increase the interest of food in other ways. So you can always make the food look prettier, make it more appetizing. Different textures, different temperatures within the meal can also help. Unfortunately, unless there's a primary reason that the person has lost their sense of smell, there's really not a whole lot that we can do to fix that. Thirst sensation, that mechanism decreases as we age, and I'm going to talk a little bit more about that when I talk about fluid. And oral and dental issues, it's probably the most recognizable reasons that people have a decline in their nutritional status. Certainly if your teeth hurt or they're loose or you don't have any or your dentures don't fit, that's gonna impact what you're able to eat. And what happens here is that even though people might be eating a good quantity of food, they sometimes have to omit groups of foods, certain types of foods. And really the cornerstone for a healthy diet is variety, so we certainly want to avoid that, and I think these are all issues that a dentist can probably manage for a person. Xerostomia is dry mouth, and what happens here, that could be the result of aging, but it's far more common that it's a result of a medication. I looked at a drug-nutrient interaction handbook, and there were over 30 categories of medications that cause dry mouth. So that's not 30 medications, that's probably 100 medications at least that cause dry mouth. And I can speak from experience. It's virtually impossible to form a bolus in your mouth if you don't have saliva. So what happens here is it becomes very difficult to eat, and it becomes difficult to swallow because you can't form a bolus. So, a nutritionist or a speech pathologist can certainly work with a patient to moisten foods with gravies and creams and sauces. But really, since it's so prevalent that it's related to medication, we really want to evaluate the medications that the patient is on to see if we can make some changes that can improve this. So as if that wasn't enough, there are a whole host of other things that happen as we get older, which can impact our food intake and our ability to maintain health. I don't have enough time to go over all of these. Each one of these, I think each category can be its own separate presentation. But the important thing as you look at the list and you see what some of the problems are, like the psychological problems require maybe mental health practitioners. Some of the socioeconomic problems, people would benefit from a social worker. A dentist can help. So it's really getting people to eat enough food is really a multidisciplinary approach. Believe it or not, it's not a can of Ensure can't solve every problem. So it's really important that we recognize that there's a whole, it really takes a village almost. And so it's not all bad news. It's not inevitable that we will have a decline in nutrition and functional status. And these two wonderful women, of course, they're probably outliers, but they're certainly an example of what good nutrition and exercise can do. Quite frankly, at 83 years old, I would be happy if I can do child's pose. So I didn't want it to all be doom and gloom. So what are the basics? What should seniors eat? Calories. So the important thing about calories is there really isn't a number for this, right? Because everybody has different physical activity levels. Their body composition changes are different. So it's not like I'm going to recommend a number, but what is important to comment on is that, as I mentioned, the basal metabolic rate does go down as we age. And so we need less calories. But what's interesting is that studies show that even given the fact that seniors need less calories, they still don't get enough calories. And this is a problem because if they're not getting enough calories, they're not getting enough protein, they're also not getting enough micronutrients. So, a weight loss of about 5% per month warrants medical intervention. It actually is a risk for malnutrition. So we want to pay attention to red flags. If people can't consume enough calories or losing weight, they might have other nutritional compromise happening as well. Protein. I think I mentioned one of the biggest threats to living independently is loss of lean body mass. And protein is one of the nutrients that can really help to impact this and delay, depletion of muscle stores. Now, according to the RDA, which is the organization that sets nutrition standards for people, older adults don't need more protein than younger adults. But studies show that people who eat the most protein have the least loss of lean body mass. So it makes sense that maybe, since we're so concerned with muscle loss in older adults, that they should eat more protein. And there are some organizations and people who recommend a moderately high intake of protein for seniors in the range of 1 to about 1.5 grams per kilogram per day. And the thinking here is that more protein can overcome some of that anabolic resistance that makes it harder to maintain muscle and build muscle. Certainly, somebody who has renal or hepatic issues, that might warrant restriction. But for the most part, I think it's pretty safe to recommend higher protein for older adults. Fluid. I think fluid is probably one of the most under-recognized issues when it comes to aging. What happens as we get older is we lose total body water. And so that creates a smaller margin of safety for protecting us from dehydration. And when that's coupled with the fact that thirst sensation is diminished, that can really put a person at risk for dehydration. I think, working in a hospital, I think the number one reason that I see with most older adults is that they come in, they're admitted, they fell, they fractured, they broke something, and they did this because they became dehydrated. 30 cc's per kilogram of body weight per day is about the minimum goal that you need to shoot for. And another thing to remember about fluid is, the patient isn't going to be thirsty, so they're not going to feel like drinking maybe. There might also be some cognitive issues happening, so not only do they not feel the need to drink, but they also forget to drink. So if you're working with older adults, you really want to plan. You want to have a plan for them to take in enough fluids. Fiber, very important for gut health. Most people don't eat enough fiber. The recommendation per the RDA is 21 grams for women and 30 for men, and that should really be the minimum level because that's not a lot of fiber. And one thing to remember when you're telling people to eat more fiber, that you also have to tell them to consume adequate fluid, because if you don't, then they're just going to be more constipated. I'm just going to talk very briefly about micronutrient status, and I'm just going to talk about one mineral and one vitamin because I think they're so important to bone health. and it's so crucial to keep people functional and independent. So vitamin D, very important for the bones. Most people are deficient. Elderly people are more deficient because they don't synthesize the vitamin D from the sunlight through their skin. They might also not be in the sun as much, especially if you're in a northern climate and it's icy out, it's snowing, raining. Elderly people are going to want to stay in and not risk a fall. As we get older, there's decreased absorption of vitamin D because the stomach acid content has changed. People might be taking laxatives. This is one of the vitamins that is malabsorbed. And most people just don't eat enough vitamin D in their diet because it's not something that's well dispersed throughout the diet. It's mostly in fatty fish and dairy foods. So the RDA, this is one of the few nutrients that the RDA is higher for adults. And it is set at 400 to 600 IUs per day, but studies really show that you need 1,000 IUs per day to prevent falls. So I would say across the board, every older person, certainly every woman after they enter menopause, should be on a vitamin D supplement. And calcium is the other one, very important for bone health. A lot of the reasons that it's not absorbed well are the same reasons that vitamin D isn't absorbed well. One of the things to remember about calcium absorption is if vitamin D is low, calcium absorption is going to be low. Again, laxative abuse makes it harder to absorb. Most people don't eat enough calcium or most people drink calcium. But most people don't get enough in their diet because people are avoiding lactose for a number of reasons. According to the RDA, this is actually higher for older adults than for younger adults. So we recognize the need for calcium. The thing with calcium is like 99.5% of total body calcium is found in the bones. So obviously, dietary calcium does have an impact. And I would suggest that everybody as well take a calcium supplement. And calcium citrate is just better absorbed due to the low acid environment in the stomach. So let's see. So what are some of the approaches to preventing nutritional decline? Every national survey that's ever been done has pointed to the fact that older adults don't get enough vitamins or minerals. So I think it's pretty safe to say across the board everyone should be taking a fairly decent multivitamin. And I really can't say this enough. Nutrition is a really good preventative tool, but it's not a great treatment tool. So it's really, at this point, it's really about early recognition through screening and hopefully to identify things before they become a problem. And I'm going to share with you a nutrition screening tool that is validated in the community for older adults. And it could serve as a really good, red flag if a patient is entering that phase of nutritional compromise. Again, it's really important, this is a multidisciplinary approach, so it's really important that we figure out why somebody's not consuming enough nutrition, why they're losing weight, because the answer isn't always in a can of Ensure. It could be that they need mental health services, or they might just need Meals on Wheels. So it really takes a team approach. It's really important. I've mentioned a few times that nutrients are malabsorbed because of drug-nutrient interactions. There are plenty of drug-nutrient interaction handbooks on the market, and if you're going to be working with patients, I suggest you purchase one. When I first started out as a nutritionist, I had a drug-nutrient, it was like my Bible. And I don't think there was one person who was on more than 2 or 3 medications who didn't have a significant, according to the guide, a significant drug-nutrient interaction. So it's really important that we view medication lists as part of a nutritional assessment for patients. Referral to a registered dietitian can do wonders. A dietitian can, certainly evaluate food adequacy. They can make sure patients are eating enough protein. They can help with sensory changes. They can even help with them accessing food. For people who are on therapeutic diets for renal disease or cardiac disease, if you're not eating enough, sometimes liberalizing those restrictions can help somebody to improve their appetite. So whenever possible, as long as it's not medically contraindicated, we want to talk to the physician, about maybe easing up on some of the dietary restrictions to improve intake. And I didn't talk about this, and addressing overweight or obesity is really an important thing for seniors, because being overweight doesn't ensure that you have adequate lean body mass. It doesn't ensure that you are consuming enough nutrients. In fact, if you are overweight, you're likely to have low-level inflammation, which actually breaks down lean body mass. So just because a patient is overweight, don't think that they're adequately nourished, because there's plenty of food out there with lots of calories that are very nutrient poor. I always have to give a shout out. No nutrition lecture or speech is ever complete without mentioning exercise and the important role that exercise has in building lean body mass, as well as burning calories and maybe helping with some of that intra-abdominal problem we have going on. And this is what is called a mini nutrition assessment, and it is a validated tool that you can use in community settings to really, it's a red flag if somebody is having problems with nutrition. This is sort of a good screening tool to use. I think that anyone who fails or doesn't pass with flying colors on this mini nutrition assessment should see a nutritionist. Unfortunately, most people don't see a nutritionist until they get to a hospital, and then you fail our screening tool, and then everybody gets to see a nutritionist. Unfortunately, by that point, once you failed our screening tool, we're really not in preventive mode anymore. We're more in treatment mode, and a lot of times it's too much of an uphill battle for people. And I generally don't like these schematics because I thought that food gut pyramid was just so confusing. But this is done by Tufts University. It's My Plate for older adults. And I like it because, it sort of does highlight the need for more fluids, a variety of fruits and vegetables, high fiber foods, talks about seasoning with herbs and spices. And so that's available on the internet for nothing. Okay, does anyone have any questions?
Hey, thank you very much. Can you talk a little bit about vitamin supplements? I'm specifically thinking one-a-day type that you get at CVS or something like that versus the more expensive natural vitamins that they sell in the health food store. Is a vitamin supplement worth it? Would that cover the vitamin D?
I think a vitamin supplement is necessary. There's as far as recommending brands, that's sort of a difficult thing. I mean, I have certain brands that I like to use. There's they're kind of hard to get, I think, in the retail setting. But I think I think a good multivitamin. I don't, QD. What is that? GNC. That there are some issues with some of their supplements being bioavailable or being contaminated. And I wish there is an organization that does evaluate nutrition supplements, and I'm blanking on the name of it right now. What is it?
Consumer Lab.
Consumer Lab would do, yeah, there's something else too. But yeah, Consumer Lab could do that, and I would reference them and see if you can get a brand name for that. I like Innate. I like a company called Pure. There's a lot of there's a lot of different ones, but what?
Pure encapsulation.
Yes. Mm-hmm. Yeah, Pure encapsulations. So yeah, I'm not so certain about the brands that you can buy in the drugstore. I for myself buy a better brand, but I think you can buy something like Innate. You're probably looking at spending $20 or $30, but that might last you 2 months. Okay. All right. All right. Thank you, everyone.
Karen, thank you very much for a comprehensive review of important nutritional factors to consider, and in terms of some of the neurological patients where there's a conflict between the proteins and the pharmacological agents. It's not a small factor when you're eating along with your medications. We're going to go with one more speaker before a larger break. But I do want to have you just stand up for a second and stretch your body vertical. It's required by my profession to say, do not sit more than an hour. So not leaving the room, just stand, move your feet a little bit, get some stretching going on side to side.
Left alone.
Okay, thank you. Our next speaker, Luis Rocalme. Dr. Rocalme is going to speak about aging and swallowing. What is going on? Dr. Rocalme has got a very broad and renowned history in his professional accomplishments. He's associate professor of speech language pathology at New York Medical College and director of the Center of Swallowing and Speech Language Pathology at New York Presbyterian Brooklyn Methodist Hospital. He completed his PhD at the Graduate Center at CUNY. He's authored articles on dysphagia, multiculturalism, cultural competence, leadership, quality improvement, and a whole range of professional and clinical areas. He's presented locally and internationally. He's served on a number of boards, a couple of the long list just to mention. He's on the board of directors of the International Dysphagia Diet Standardization Initiative, a worldwide activity, and past chair American Board of Swallowing and Swallowing Disorders. He founded the Hispanic Caucus for Speech Language Pathology and Audiologists in 1992, so a little broad base of professional issues and cultural issues with his work. His research is focused on changes in swallow physiology in the presence of swallowing pills, as well as pathophysiological changes of swallow, interest in dementia. So very germane for our discussion here today. He also writes and presents about the impact of culture on our work. So I welcome Dr. Rocalme.
Yes. We have a little markers as to where we can stand, and I'm not good at this. I like to walk around. So we will see how this aging, swallowing, and not walking around is going to work. Yeah, but that's the last slide. We want to go over the top. And I love having good AV people. Thank you, sir. Okay, so this aging and swallowing. So you all love to talk and swallow. So I love being a speech language pathologist because of that. You also practiced some swallowing a little while ago, right? You had lunch, and there were all these different textures back there. Did you notice that? Right? You probably didn't even pay attention. Maybe you were thinking about the nutritional value of what was on those platters, but very few people think about the textures. But what if you had trouble with some textures? Now you have to start making some decisions about what you can eat and can't eat and how that will impact nutrition. So I want to thank the organizers, not only for inviting me, but also for the great talks that we've been hearing. And I love how things like functional reserve that we talk about in speech language pathology, things about nutrition that we also talk about in speech language pathology, kind of all come together here. Obviously, you see this is that beautiful school where I work at New York Medical College. But I also get to have some fun at New York Presbyterian Brooklyn Methodist Hospital. And I used to call this the adult team, but it turns out that the speech pathologists that work with children are also adults. So I can't call them the adult team. But we're missing two in this picture because we've been growing, which is a wonderful thing. But they're part of the team that has fun with me over at New York Presbyterian Brooklyn Methodist Hospital. So let's share some introductory thoughts here. I think, when we're talking about older adults, and also be careful what you call them, right? Because we talk about elderly and all these things. And I'll tell you, my two sisters are in their mid-70s, and only about a year ago did they start letting me calling them old women or elderly, because they're like, no, right? Where did that 65 number come from? It's politics. Medicare came up with that, exactly. And then we followed, and researchers followed that, and so 65 plus. And that's why it's so important now to not just treat 65 plus, because we have really healthy, wonderful people running around town at 70, 72, 75, right? And so we need to start including folks that are over 80 and are still aging in a healthy manner. So really, really important to keep that in mind. In terms of swallowing, you think, well, where do things change? Well, just like our physical therapy colleagues spoke about frailty and some other changes, have you thought about the muscles that we have in our tongue? How about the muscles in our throat, which we call the pharynx? right? How about the muscles that help produce voice? Why does our voice change with aging? Ah, you hadn't thought about that. You only thought about hand grip and the biceps and walking and climbing stairs, right? So really interesting stuff to think about. The other thing is, in geriatric medicine, trouble swallowing is the second most commonly reported symptom. And yet those folks are not always referred to a swallowing center or to swallowing experts, okay? So that's a big, big deal. And very often, sometimes geriatricians will recommend thick liquids, which I hate, or do some other things rather than really find out why is the person having a problem. It might be a normal change with aging, or it might be pathologic, as Karen mentioned when she was talking about nutrition. And so, and we see already, right, you have some recent data there from Chen and others, that 15 to 38% of healthy community dwelling seniors might have difficulty swallowing. And that just advances. And then if you're, and by saying, and then what if someone develops a urinary tract infection? Now they're dehydrated, decompensated, admitted to the hospital, and they call in a swallow consult by the speech language pathologist who really says this person can't swallow. Well, that might be temporary. So let's get nutrition up, let's get physical activity up. Let's put them on a modified diet for now, but our goal is to get them back to that baseline diet, not keeping them on those delicious thick liquids and puree diets. Didn't Karen mention something about the food has to look good if you can't smell it? Let's look at visual. Well, puree diets don't look too good. I'm letting you know that. Okay, so I just want to show you what the normal swallow is like, and I'm not sure what the pointer, oh, here's the pointer. Okay, sorry for the folks that are on Zoom. But so when we talk about swallowing, a lot of the literature, especially in medicine, talks only about the esophagus. As a speech language pathologist, the esophagus to me is gastroenterology's territory. I'm all about the oral stage or the mouth and the pharyngeal stage or the throat. Okay, so we have the oral stage right here. So all that chewing, all that fun stuff we do. Did you think about chewing? You only thought about your teeth with chewing. What about all the work your tongue does, right, to keep that bolus going? And I have no idea what just happened. There we go. So, so this is where we do all the prep, and then we push that bolus or the food or liquid to the back of the mouth, right? And this is where all the big sensory receptors are to send the message to the brain and say it's time to swallow. And then when we swallow, there's all this great activity. I won't bore you with the details, but this is what I love to talk about. And that's where then you have your soft palate, that little bell that hangs in the back. That moves up and helps food from going up to your nose. Isn't that a wonderful mechanism? We're created so beautifully. We're all gorgeous inside. Then we have the throat or the pharynx, where we actually start squeezing the bolus inferiorly, the food down, and then you say, what happened to the airway? You see, this is your airway in front, and this is your esophagus in the back. But you say, wait, it's going to go into the airway because the airway is just open, and it's like a big avenue. Well, we close this off, and there are 4 different mechanisms to close off the airway, and when we swallow, that actually all comes up and hides under the base of the tongue, which is why our Adam's apple goes up when we swallow. And then that relaxes the entrance to the esophagus and the food goes in. Is that exciting? You're almost swallowologists now. Because you just figured that out. And let's just see how we're going to get this video to play. There we go. Watch a normal swallow. It's beautiful. Propel it posteriorly, trigger that swallow, close that airway, move it up, get it down there. Almost exciting. Almost exciting. Okay. So then, and these here right now are some of the things that we knew even back in 1989. That's an old study. But we've continued to confirm that we know about these things in just healthy aging, right? These are the things that change in healthy aging. So the swallow's a little slower, the squeezing takes a little longer. There are some changes in how we propel that bolus. But more recently, if you look at the bottom of the slide, we see Mulfenter and Lazarus' work, and they're over at NYU, here in the beautiful state of New York, have been looking at some interesting information also in healthy aging. Things like, well, if the pharynx or the throat are all these muscles that squeeze the food down, what are the changes there, right? Because what we know about functional reserve and what we know about resilience has a lot to do with the tongue. And that really started from work done in Wisconsin in the mid-90s, thanks to physical therapists talking about sarcopenia. And that literature drove some of our colleagues in Wisconsin to start looking at the tongue, and the front of the tongue and the back of the tongue, and I got all excited when Nikki mentioned the fast twitch and the slow twitch, because we never say my tongue is tired, I don't want to talk anymore. But yet as we age, sometimes you start feeling changes in how your tongue can handle certain textures. Okay, so something to think about. But what they found with their MRI study was actually that the muscles in the pharynx or in the throat, okay, first of all, the space is larger, right? So we know there's some muscle wasting there. But then what else did they see? They really saw that the muscles were actually thinner than they were in younger controls, okay? So they're starting to look at that. I need to mention aspiration because that is a word that is so overused. Aspiration. That basically is something went down the wrong way, right? So the airway didn't close off, so either food or liquid went down the wrong way. What is the most difficult thing to swallow? You're going to think of bagel, but it's not a bagel. Water. It requires way more neuromuscular control to keep everything closed off and not let it seep in where it's not supposed to go. Okay, so really, really important to keep in mind. But this aspiration thing, the first question I ask when somebody says, oh, the patient's aspirating, well, what are they aspirating on? Right? Because we swallow things differently. We swallow liquids differently than we swallow soft foods, differently than we swallow harder foods. We also will manage and swallow differently based on the taste of the food, based on the temperature of the food, based on that texture. The way you swallow mashed potatoes is not the same way that you swallow roast chicken. Okay? Very, very different. And then that martini goes down differently as well. Usually by the third it goes down really differently. Okay. Nobody cares about laryngeal penetration. We do as speech pathologists. That's when something enters the airway, but it's clear, it doesn't make it past the vocal folds. And I only mention that because I think sometimes there's that distinction and someone might cough just by material entering the airway, but it doesn't necessarily mean they aspirated and went all the way into the lungs. Okay, so we just need to figure that out. This is still a landmark study looking at how we at predictors of aspiration. Aspiration, the event. But look at the first one there, and they're in order. Poor posture. Okay, we need to collaborate with our colleagues in physical therapy and occupational therapy, right? Because poor posture is not a good thing. And then there's residue, there are changes in voice that we need to be paying attention to, etc. And how about those that are more prone to actually developing a pneumonia from that? Of course, poor health status, unfortunately, age is up there. So, of course, if they have prior history, but also the presence of any feeding tubes, and some of that data is a little old, because a feeding tube doesn't necessarily need to be a horrible thing, and it certainly can be a temporary thing. Unfortunately, many times we think of it as more of a full-time, go for it thing. Also, with feeding tubes, especially the gastrostomy tubes, the ones that are in the stomach, unfortunately, too many times these are placed and then the patient is told you can't eat anything by mouth. Think about that quality of life. Nothing by mouth and only fed via a tube in the stomach. Horrible. That's not true. Okay, it is our job to figure out what somebody can swallow safely. It might not be enough to maintain full nutrition, okay, but food is pleasurable. Food is social, right? We always think about that. When you form study groups, when you get together with friends, what are we going to drink and what are we going to eat? Okay, so depriving somebody from that is it's horrible. I'll just show you what aspiration kind of looks like, and here's somebody with a liquid enter. Right into the airway, you saw that, huh? Okay, I'm going to skip this slide in the interest of time, but I just want to tell you that sometimes people do cough for a thin liquid like water, but then when they're given a thicker liquid, let's say they thicken up something like a cranberry juice, because some people believe that that's just a better alternative, the person might still aspirate but not cough. It's a different texture, right? It's a totally different texture, but also think about the pre-planning for that. When I am drinking cranberry juice, I'm expecting a thin liquid. I don't expect something thick, right? As opposed to if I'm drinking a shake, then I certainly would expect something a little thicker. Okay. At New York Presbyterian Brooklyn Methodist Hospital, and Karen doesn't know this, but it's all her fault. We started some years back to recommend clear liquids because we know that that the lungs can handle things like water and clear liquids like apple juice a lot better. So many times when we saw a patient at bedside, the speech pathology team would recommend these clear liquids along with a diet, maybe along with a CHOP diet, sometimes even with a regular diet. And we didn't see any changes in the rates of aspiration pneumonia. We were doing that because based on our bedside exam, if we didn't have a chance to get them down to radiology in a day or two, let's say it was the weekend, etc., we felt that was a safer thing to do than to give them thick liquids. Well, Karen comes along, what, 5 years ago you started at the hospital? 4 years ago, and we just have so much fun there. And she said, so listen, you know, my team in clinical nutrition thinks you guys in speech pathology rock. And it's always good when you start a conversation that way. I love it. But then what's this clear liquid thing and what's your thinking? And then she said, what's your evidence? Right? And I said, oh dear. Well, we know this, we know that, but you know, that hasn't been published and this hasn't, okay, so then you start thinking, okay, where are we getting this from? It was working. So we actually were able to obtain some level 4 evidence, basically some expert opinion, 2 folks that we really respect in our field. One that does a lot of work in the rheology of liquids, or the composition of liquids, viscosity, yield, stress, all this fun stuff. And another one, Susan Langmore, who actually wrote this about the predictors of, or did the humongous study on the predictors of aspiration. And they both said, listen, we know that fatty substances and highly acidic substances are not good for the lungs. But people can aspirate other things, right? So the Asian community, which was increasing at our hospital, when they were asking for jasmine tea, we didn't know if we could let them have jasmine tea if they were at risk for aspirating. So right now, we're about to submit to the IRB at the hospital a study that we put together that incorporates quality of life and looking at aspiration, pneumonia rates, etc., looking at these neutral liquids because we have to come up with another name. Because clear liquids were being confused a lot by our surgeons when they put people on clear liquid diets after surgery. All right, so that's just so if you want to use the term neutral liquids and nobody understands you, they shouldn't, because it's only a Brooklyn thing. All right, I'm just telling you. Hopefully soon we'll find out more. This is just, I wanted to share with you this example because being old doesn't mean you have to be disabled. Okay, and so this is the case of an 89-year-old, and this is an old case, but I love it. An 89-year-old male who was admitted with a UTI, okay? Totally functional, living independently, oriented ×3, okay, doing well. Came in with a UTI, had some other complications, went into respiratory distress, ended up on the ventilator for a few days, then was extubated, right? And we were called in, but back then, so this is about 10 years old, we didn't have electronic medical records, it was paper charts, and it was a long weekend, and so the physician didn't follow our recommendation. The patient ended up, you know, on a regular diet, when we really had said that he still needed his nasogastric tube, which is the tube that goes in the nose, along the back of the throat and into the stomach. So we finally got him down to radiology to prove that he really wasn't doing great, and this is what his swallow looked like. Wait, let me get you to where, yeah, there we go, that's him. Nice long neck. I like people with long necks for these x-rays. Doesn't look good, right? But he's coughing, and clinically that's really good. He was coughing, there was all this weakness. His week was not productive. Okay, he couldn't get all that material out of the airway. You see that? Okay. And I won't show you the rest in the interest of time. So now, we worked with him for 3 weeks. He went to rehab. It happened to be a place where we also covered, so we did some intensive, again, physical therapy for the throat. Went ahead and then repeated the study. So this is 3 weeks later, 89 years old. little different, isn't it? Okay? So treatment works, and muscles can change, and nutrition is a big deal. Okay? So that's the message here. He did great. He was so happy. All right, so how can I talk about aging and not mention dementia? And you say, well, why do we have to bring up dementia? Well, because we're living longer, and so cognitive changes are quite relevant to this topic. The problem is in this country, we're still not doing a good job at diagnosing dementia, right? Because basically anybody with an MD or a DO after their name can slap on that label. On Mrs. Gonzalez, who came in as just a little forgetful, suddenly dementia shows up as part of her past medical history. All right, very scary. And then forget about trying to figure out the type of dementia, unless they make it to a neuropsychologist, which doesn't happen all the time. Okay, so then when we start trying to figure out the different types of dementia, it makes it more difficult because there are differences, for sure. Delirium, dehydration, sarcopenia, I just put those in there because we need to pay attention to those, and they impact cognitive status as well. Someone that's dehydrated will be cognitively affected. So I'll leave it at that. The population of people with dementia and swallowing problems is certainly growing. What's really happening? If in dementia we know the brain is changing and there's volume loss, etc., it's going to impact how we function, right? Well, but how much of that is also just part of natural aging? Because there are also changes in the brain happening with normal aging. So we know a little bit, as I told you before, from older studies about how the swallow changes. But what I want to show you here, and the next one is, this was a review done by Karen Easterling, one of her graduate students in Wisconsin, back in 2008. And so look at the difference between, for example, what they found in the literature, folks with Alzheimer's disease versus folks with frontotemporal dementia, if we have the differential diagnosis. Especially in Alzheimer's, so you see the reduction in the sense of smell, right, anosmia. Memory is going to impact nutrition because they'll forget to eat. So maybe you left mom some food so she could have, lunch this morning when you went to drop off breakfast, and then you come back. Or you might call at 3, Mom, did you have lunch? Yeah, it was delicious, great. You come back that evening and it's still in the refrigerator, okay? And then of course, we saw from before, once you need to be fed, it increases the risk. As an adult, how many times have you been fed? And I'm not talking champagne and strawberries, that's a whole other goal there, okay? All right, but we're not used to that. And then now suddenly, you need to be fed, right? We haven't developed those mechanisms to let somebody know enough food, or I'm not ready for more, or that's too much, right? Yet, and now we have somebody cognitively impaired being fed. So we really need to work on that. But then look at frontotemporal dementia. Those are folks that don't develop swallowing problems early on. They actually develop them later on. But changes in food preferences, over 90% of folks with frontotemporal dementia. And I know from working with my clinical nutrition colleagues that one of the first things they'll say is, oh, let's look at food preferences and let's see what this person likes to eat and how we can work things around. Works great for Alzheimer's, it won't work for frontotemporal. Okay, so something to think about. And then bite size and chewing, right? Making those decisions. We make those decisions all the time. How did you know how big a bite to take of the hard bread sandwich versus the soft bread sandwich that were back there earlier, right? You're like, I didn't think about it. Exactly, your brain did. Somebody else did all the work for you. This is just some data showing you that some of that information. I just want to tell you briefly. So Humbert et al. Did a great study with functional MRI, healthy older adults, early stage Alzheimer's dementia. One of the things that she found was what? As we age, okay, so there's a lot, although the whole brain is involved in swallowing, mostly the dominant hemisphere is involved. But as we age, there seems to be a shift towards the non-dominant hemisphere, which in many people is the right hemisphere of the brain, more the anterior part. Just normal process of aging. And we're thinking, is that compensation? Maybe because of muscle changes, etc. And so now the right hemisphere is kicking in to help. In folks with early stage dementia, that transfer over is not happening. It all stays in the left. That transfer over to get some help from the right hemisphere is not happening. Really, really significant findings here. I'll just share with you a study I did with some of our students here back in 2013. We just looked at timing, and if you see the timing for oral transit, for pharyngeal transit, and then overall efficiency were all slower in folks with dementia. That got us to then have a little bit more fun. So with my colleague Sonia Molfenter over at NYU, what you see is that, so what I didn't point out to you is that at the base of the tongue we have these little pockets, the vallecula, and at the entrance of the esophagus we have these other little pockets, the piriforms, and they're great. They're protective, right? You put too much in your mouth, some of it went into your throat or your pharynx before it should have. You have those little pockets helping you. And but they also sometimes, if you don't have a good squeeze, you might have some leftover, which is what you sometimes sense and why you might swallow something a second time or a third time. It's not always left over in your oral cavity, okay? So what we found in this study was that out of 60 participants, we found that there was more residue for thin liquids in the piriforms. And we're thinking, well, if there's more weakness in aging, why didn't it happen more with the semi-solids? So now we're trying to figure out what about the sensory changes going on, the sensory receptors at the base of tongue and the posterior portion of the velum and other parts of the oral cavity. So we have to take a look at that a little further. So now comes Dr. Namasivaya McDonald, who's over at Adelphi, joins our group, and we just keep having fun. And we just recently presented this in Ireland. No, I didn't go to Ireland. She presented it in Ireland, but it was our work. Here we looked at some more folks. This is a scale that we use and we trace with this free computer program from NIH, and that's how we can figure out the amount of residue. And in terms of size of neck, etc., we measure, and the scalar is really level C2 to C4. And then we put this on a spreadsheet, and some engineer genius came up with a spreadsheet that then calculates it for us, so we can compare residue with the different sites in the throat. So what we found was that safe swallows are more common in folks with dementia than unsafe swallows. But look at that third bullet. Thin liquid residue in the piriforms, which Dr. Molfenter and I found before. Now as we analyze it for risk, it triples the risk of aspiration. So all that, where's it going to go, right? Once you go back to breathing and that airway is back at rest, boom, it's going to go into the airway. So how do we prevent that? How do we work on that? Is something to mention. And this is the last topic, and I will be quite brief because this is certainly material that's in development. But I'm interested in how we swallow pills. Why? Because of all the medications that people are taking, etc. We know about polypharmacy with older folks, etc. And most of the literature out there talks about esophageal transit. Your Tylenol soft gels that say easy to swallow, proven scientifically, they only measure transit time in the esophagus. Nobody looked at the oral or the pharyngeal stages of what's happening with the swallow. Okay, so, and when you speak with nurses, and we surveyed nurses before we started this, they'll either crush the medications or they'll give the medications, what do they usually do with water, or they give the medications with applesauce, right? And so that's how we designed our study. Polypharmacy is just rampant. And so also the other issue is there are 14 different sizes and shapes of medications, right? And textures and all this other stuff. And then usually they show up in this little medicine cover, you take them all at once, right? Well, you have a great swallow, you can do that. But sometimes older folks can't. The medications that older folks over 65, oops, I almost said older folks, that folks over 65 take, all these are very small tablets. But what's the problem? People also take multivitamins and the calcium supplements, AKA, my friends call them the horse pills, right? And so those need to be attended to. All right, so let me just show you. So we really did a pilot study where we didn't use contrast material, but that's what the pill we're using. We decided to use a capsule, fill it up with barium so we can see it on X-ray. And so what we identified were 14 different patterns of swallowing pills. And we found that 21% of folks will use a different pattern when they swallow pills with liquids versus when they swallow pills with applesauce. All right? Is that cool or what? To me, it drives me crazy. Now, how am I supposed to help somebody swallow pills? I need to figure out what your swallow pattern is. How do you normally take pills, right? So, but then let's think about now folks maybe with some cervical spine problems. And if they're typically using the head back, now they can't do that. How's that going to impact their ability to take medication? We never think about that, do we? I'm sure you were thinking about that just this morning. I certainly was, but I like this stuff. So here's an example, and I'm wrapping it up, of what it looked like without any contrast material. This person had water. Okay, that's a pill going down. Is that cool or what? I know you're joking for joy. The current study we're doing, we're randomizing, we're doing applesauce, we're doing pudding, and we are doing the contrast material. We have found changes, but non-significant changes in timing, although there's been a trend for slower oral transit. There are changes, and this is that residue scale that we've been talking about, where we have seen some changes again in that piriform sinuses, so we need to figure out what's happening there. And I'll show you then what that looks like, and then I will let you take your, I understand they promised you a longer break. Okay, now that's this delicious apple-flavored barium liquid with the pill. And look, the pill disappeared, but look, there's residue in those little pockets, right? In the piriforms and in the and in the vallecula. Is that great or is that not great? So in the vallecula, at the base of tongue, so the base of tongue has a great functional reserve. It seems to compensate whether it's liquid or semi-solid or whether that solid pill is in the way or not. But we're having issues with the piriforms, right? That entrance to the esophagus. So why? Is it that the airway isn't going up enough to relax it? We have to really take a look at and how that's all really working for us. So we can't overestimate the role of decompensation, how it impacts swallowing, and all the fun things we do. Thank you so much for staying awake.
Thank you very much, Elise. I'm not sure anything what's going on, but I'm confused on a much higher plane. So,
we have time for a couple questions, I think. Just a couple.
I will give time for a couple of questions. So, come on, come back, please.
Oh! And so what might you want to ask?
So we have no questions.
So we have no questions. There you go. All righty. Thank you.
We're going to have a break before Master Yang is talking on key volume time sheet. Can I have a hand for all the speakers that let us talk today? I'll go back to make it senior. So we'll take about a 5-10 minute break before we go to our last keynote speaker. So thanks for a good session so far. Come back again.
You know, I'm not good with those idiomatic expressions. I should have said it, but I didn't say it. But I usually put that at the end of my time.
You're very good making the race.
And please don't find a seat if you didn't just the questions for you. Up to enough to whatever.
But yeah, we gotta make it fun. I'm gonna.
This is fun. Alright, so I'll see you in DC.
Oh my gosh, yeah. If I don't see it tomorrow, but I probably will see tomorrow. I get ready. I have it in my car. Tricia says she's got it today. So I'll give it to you and she'll get it from
What, so you printed it?
Yeah, it's in my car.
Blood test now.
I'm sorry I was out of the room for a little bit.
Oh, no problem.
But I have a 91-year-old mom who hasn't been able to swallow the 16,000 polypharmacy.
Oh my God.
I'm just curious, are you working with anyone in the pharmaceutical industry to address this?
As I actually a colleague in Australia who's a professor in the School of Pharmacy at the University of Queensland. He's very interested in this, and I actually supervised two of his students that were working on their thesis. They came to New York and spent 6 weeks with me. And they surveyed pharmacists on the same topic of what do you tell people when they come and they have to swallow? So yes, when I've spoken with some of the of the folks that actually create the medications and so on. Many times some of the limitations is they're looking for a size that's going to provide an effective dosage and this and,
And you
that.
realize that takes rescaling the entire
Right.
manufacturing process.
Right.
I've worked in clinical research for 30 years, and I work with some of the major pharmas in the country, and I don't think that this is a problem that they don't want to address, but I don't think it's a problem that's gotten enough.
And you know what? And I think we need to go to them once we have the physiology.
Yeah, absolutely.
Really what's going on.
Yeah. Oh, that's my
There you go.
That's my name.
So that we know what's going on. So that's part of the analysis that we're doing with our samples. So we got to have a good sample. I need to get the patterns of swallowing that paper. Hopefully in the next few months I'll be submitting it to publish.
There's all different types of formulations that could do. There's suspensions, there's lozenges,
Right, but not all of them are possible, right? Like sometimes we'll say, oh, let's get it in liquid form. Let's do this, but not all medications are possible. So that's why we got to play.
And there may not be a political will to do it anyway.
Well,
Because for them to retool, who's going to pay for it?
Exactly. Because they don't make enough money right now. So.
Oh, no, I know. My heart breaks for them all the time.
Yeah.
I have to do a meeting, I'm not kidding you, it's going to be only remote with Japan for 3 days because there's no travel. What?
3-day meeting.
Yeah, my
remote.
translator who works with me. Can you imagine? No, we're going to do telepresence. Everybody will see it. We're going to start at 3 in the afternoon and be there till 10 o'clock at night. And so that they can be, because they're a parent company in this case. I mean, that's the kind of ridiculousness. And yet they're
but I've
making,
been hearing that.
making millions of dollars a day.
Yeah.
But they're crying all the way to the bank. Do you have a card?
Oh, yeah, actually. I just pulled it out because she runs a Parkinson's support group.
Yeah, it's a huge issue. And, you know, I just don't think it's in consciousness to struck
It's not. It's not.
And
That's why I want to try to figure out the answers. And right now, nobody else is looking at this. A colleague in Brazil did something like my first one without the contrast, and then she's lost interest. She's going into other areas of research. But I'm continuing with this because I'm concerned about the residue, the rates, all this stuff, and then what can we do to help facilitate it, and how can we identify what their patterns are?
and I know the episode.
Oh yeah. Oh yeah.
I'm going to give you my card.
Oh yes, please do.
Four sections.
How boring is covering all these talks for you?
No, it's not bad. It's not too bad. Yours was very interesting. Even if you don't know the subject matter, it's something like
Just like the videos. It was all about the swallowing stuff.
We're going to get started now. Everyone can get comfortable, please. Do I have to lean forward to get How's that? I guess that's really forward. So, we're having a good time, and we had a really nice group of speakers on a variety of topics. And so now it's time for dessert. I'm very happy to introduce Master Yang Yang. He's recognized in traditional Tai Chi and Qigong community as a master practitioner and teacher. He's also an academic researcher interested in applying the highest standards of Western scientific process to explore and promote evidence-based Eastern philosophy and wellness programs. Master Yang trained in China under the 18th generation Grandmasters of the Chen style of Tai Chi. He was 3-time overall martial arts champion at Shanghai Collegiate Tournament and is former instructor at Shanghai Chen Style Tai Chi Research Association. A graduate of the doctoral program in kinesiology at the University of Illinois, Dr. Yang's research focuses on the mechanisms and benefits of traditional Tai Chi and Qigong practice. He's author of the highly acclaimed book, Tai Chi Quan, The Art of Nurturing the Science of Power. And I think we have a copy of the book floating around? No. Sorry, we forgot. We forgot to bring the book. But I have a copy, I'll bring it one day, and you're happy to have a look at it. And there's also an evidence-based DVD that Master Yang has made, and we can make that available to you too. Dr. Yang was honored in 2006 as the Qigong Master of the Year at the 9th World Congress on Qigong and Traditional Chinese Medicine. He is founder and director of the Center for Tai Chi and Qigong Studies in New York and has more than 30 years experience teaching Tai Chi and Qigong in China and the United States. Is it about time to say almost 40 years? Well, it's almost a year. So, and on the, his bio and abstract of his talk are included in the folder. There's a link to his website there, as well as a really interesting video of his life story, his biography. It's really fascinating. The title of his presentation is Qigong and Tai Chi, a multi-dimensional exercise for aging in place. That's enough.
So it's a great honor to be here to meet everyone and practice together. So I'm a practitioner, so we will spend most of the time do this. All right. So and so you can get an idea why this is potentially a good exercise. Maybe one of the solutions for the aging is still there. Okay. Just before I start even the PowerPoint, let's do one exercise together. Okay, let me show you first. And at the end, what I will do is I will go to the middle and to the end so you can see me a little bit better. Okay, so the first exercise, can you hear me? I'm using the mic. Yes? Okay. The first exercise is called the Rising Dragon. So let me show you first. Okay, it looks like this. First exercise. Okay. Let me tell you a little bit background. I had a terrible bike accident in 2014, and then it almost destroyed my career. And then it took me a long time to get out of the back hip pain. And then, but through that process, I identified a few exercises I do every day to prevent future back hip issue. And also this kind of exercises when I was having extremely pain there, I find out this is very effective ones. So this is one exercise. I have a few others. I will share that with you. Okay. So the first one, let me explain one more time. First, you put your hand in front of your heart. Then we'll do together. Okay. So this is the dragon going up, as high as possible. We have so many physical therapists, experts here, so you can see we'll really elongate the spine, open the hip joint. And then also our shoulder area, right? The image we have is I'm reaching the ceiling. Okay? And then you turn, and sink into the ground. You develop your routine for your balance. Okay? Let's get out, do it. Okay. Yeah, you do not need a lot of space. Just spread out and we do it together. Okay, I will face that direction so you can see me better. Ready? Okay. Yeah. Okay, one, you go up, all the way up. Then two, you turning to the back. Stay at the shoulder high, right? And then you sink your body into the ground like scooping water. Oh, yes, that's good. Then second trick, 1, 2, at the shoulder high, 3, you go down. Nice. One more time. 1, go as high as possible. And 2, and 3, go down. Great job. Okay, there are several key points. The number 1 key point is smile. That's all. So, ready? Let's just switch another arm. Ready? Okay, let's go. Imagine the dragon is going higher there. So the energy can really go through all the joints our tissues there to help the energy and blood flow there, right? Good, good, good. And again, up, 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 up. And turn. And go down. Yes. Another trick is thinking you're the best. You're the Tai Chi master in what's right? Okay, good. And go down, 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 down. One more time. Open, 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 open. Turning the body and good. So our physical therapist teachers and professors talking about flexibility. In Tai Chi we call it spiraling flexibility. So it's not you are opening, you are turning, create this unlimited possibility to open the body, right? So it's called the rising dragon. That's the first exercise, right? Since we get up already, let me show you another one, simple, which is called agility training. Let me show you first and then we do together, okay? So all we need to do is put one foot in front first, okay? And then let me stand back here so you can see my foot, okay? So 1, 2, 3, okay? 1, 2, 3, let's do together, okay? 1, 2, 3, 1, 2, 3, 1, 2, 3. Again, remember the first key point, smile. Okay, I really mean that, okay? And then you think, I'm the best in my thing, okay? Whatever you want to call that, okay? Yeah? So, change. You know, we've been talking a lot about aging. It sounds a little bit depressing, right? But let me tell you one thing. Okay, here you think about it. Let's try one thing. As you move, keep moving, keep moving. And the second key point, you think about it. You see how your body responds. See, my body is 5 years younger. Think about it. Yeah. Just keep moving. I really mean that. Okay, think. My body is 5 years younger. Keep going, keep going. This is called the warrior jump. Yeah. Okay, keep going, guys. Keep jump there. Okay, now listen, please. Now we're going to get 7 years younger. Let me show you. Keep going. Jump there. This is. Let's keep going. You guys jump. How about that? Let's get 10 years. It's really intention. Now you know what? I'm gonna go to the mirror. You have to do it. You know, think about this. This is an exercise. I'm gonna share with you these classical exercises. If you try this, remember what I said today. It can benefit the rest of your life. I really mean that. Okay? So here, let me go there, show you again. So the key is, our mind is very powerful. I can land like this. I call that jump like a tiger, not like a cow. Okay? So here it is, you jump. Same thing, you can make it so heavy that cannot move. But you have the mindset, say, my body is 5 years younger. You don't have to jump high, just the intention. Yeah. Let's do it together. I really mean that, okay? Yeah, just to say, and we also, with physical therapy, we talk a lot about core strength. We talk about the function, how you make the core strength functional. Let me give you one trick. Yes, you initiate the movement from the core. Yeah, just have that concept. Have the concept, I'm moving from my core. It's reading to the rest of your body.
Hey, bro, you're going to be 20 years younger when you get done with this.
Okay, let's get 7 years younger. Come on.
And really cool down there, yeah. Now, as we put, I want to mention one thing. Your physical therapist probably heard about Hospital for Special Surgery, right? In New York. One day I was giving a presentation to the physiatry department. And at the end, the physiatry said, "How come your Chinese so smart?" I said, "What do you mean by saying that?" Because, in Tai Chi training, you talk about initial movement from the core. We call it energy center. You initiate everything from the core, and it has been talked about 500 years. And then he said, as Western science medicine, we only started thinking about this 30 years ago. It's not too late. The key is when you move this thing, it's from that core. Right? So you go to the cardio, you go to cognition, you think about this. Well, you guys are so smart, it's good. And then when you go to the patient population, just by doing this, cognitively, you are not believe how many people cannot do this. So lift the front, 1, 2, 3. 1, 2, 3. 1, 2, 3. It's cognitive training, and also because you are standing on one foot, it is balance, right? And it's a functional balance training. You got to stand on one foot, then you think about that you have to jump, and then make it light. It's a timer, not like, oh, okay. Okay, have a seat. So,
You got room for it, Chad?
I love that. It's a timer, not a
Test it out this week.
That's gonna work for me.
Dr. Knapp, please remind the time. I'm an artist, like I need to play music. I put that time. Okay, so first, I have been running this center, trained teachers, and also working at Snow Catherine to help our cancer survivors and patients. I also want to mention my great colleague, expert master therapist, Rocco. Please raise your hand. He's here. Yeah. So you may say, what is Tai Chi, what is Qigong, and what's the health benefit? That's what we're going to talk about today. And then what has to do with aging in place. Okay? So that's what we're going to touch, these several things. And then the first one, aging in place, Dr. Knapp just mentioned at the very beginning, but these are the several areas Tai Chi Qigong might help. And then one is the safety, and how we keep our elders or even younger people there who has to be in that place safe, and with the strength, balance, all these issues, and also mind, sharp alertness, all these issues, independence, and also comfort. Doesn't really matter your age there. And then, so how we accomplish that? And the Tai Chi Qigong might touch all of them. And then, so first, what is Tai Chi, what is Qigong? Simple definition is Qi means energy. It might sound like mysterious, actually it's very simple. It's energy. And here in this culture, we talk about energy as well. They have lots of energy. That's it. And then, so then Gong means exercise. So Qigong together means the art of cultivating, balancing our energy, and actually conserving our energy. It's like an energy account, I call that, okay? And then, so what is Tai Chi? Let me back up a little. What is Qigong is, we want to accomplish the energy goal there, right? How to do that? There are two big categories. Static means you don't move, and dynamic, you use movement to generate, and when you do the movement, you put different individual exercise together with choreography. So that's Tai Chi. So in other words, Tai Chi is the one subcategory of Qigong. Very clear? Okay. So now, overall is why so many people doing Tai Chi in China? Okay? And then actually it is very simple. People like here want to keep the vitality when you reach certain age. We talk a lot about screen and talk about the, find out where the problem, but here this is an art that can help us delay or even reverse some of the things we lost. You can think like the jump we just did, you try a couple minutes a day, you will see. My recommendation today, go back, use your phone, videotape yourself, leave there 1 month, do this exercise after you study your 2 hours, put down your book, just do this one. And then just increase the intensity, only 3 minutes, 1 day. And 1 month later, you see your body change. Okay, so here is, actually our thing is, why in China so many people doing that? There's no option. You have to live in your home. There's no nursing home, no that kind of exist. And then, so which is a bad thing, it's also a good thing. It forces people to think how I rely on myself. It's interesting, at Sloan Kettering, I have one patient in a class, she's a physician. She said, now I just realized there's a big cultural difference. Here we rely on healthcare, we rely on doctors and give our pills. Okay, one for doctors. Okay, I'm just saying, she's a doctor herself. She said, but it's interesting listening to your talk is in your culture is how much you're relying on yourself. Because you don't have the choice. Okay, so the question is how we translate some of the wisdom there to apply to our society. And then, so health benefits, again, sleep, stress, cognition, the balance, strength, I just mentioned several relate to our topic here. And then, so, and also very brief history, how I started. That's me, myself, and my sister. So here is, you may say, oh, it's strange, your name is Yang there, so why you keep it simple? That's simple. I said, no, it's not simple. My name means change. Why my grandmother gave me this name is I was born with a congenital heart condition. And then, so there's kind of like my grandmother said, I want my family's energy changed. So give me this name. Okay, and then I was kind of like, my family could not afford the surgery and then any treatment. So it happened in my hometown is the original place where Tai Chi was created. And my uncle is a master certified in Tai Chi. And see what happened. So when I was 12 years old, I started to practice. The change I felt was in the winter, it's snowed in China. It's snow like this year. And then every winter, I started feeling I could get warmer. I said, oh, this is something I can change, right? And then, that time we have some Chinese colleague here. They know the history is around 1977, the China just changed the system. And in order to get to college, you have to pass number 1, academic, like here. Number 2, physical. They have physical checkup. If you have a heart, any condition, you're out. So I went to the physical checkup and find out my heart condition was gone. That's the biggest psychologically, I feel, oh, this is something can really change. That kind of started putting me onto this path and how to apply this art to help others. And then, so I went to college, joined a martial art team, and as Dr. Neff said, I got the championship. You might think, oh, this is impressive, right? I tell you very soon, nothing, okay? So, then tell you the story. So, and then today I selected several exercises, and then after this really more than 40 years practice, I'm giving you some very, very essential things. You practice today, just do it, even you think you just start today and see what happens to your body. So it's not only for our elders, for caregivers, and for all of us here. So let's say, overall it has both 2 parts, mind and the body. For the mind, for the body part, it has a static and dynamic, and for the mind, it's the meditation. So for the body part, and the standing meditation, this is something, it's really, really counterintuitive. You see, if you have friends with a sleep issue, try this one. And then see what happened to the sleep, okay? And then, so let me show you what it looks like. It looks like this. 1 foot in front, actually we just did the application, you jump into that, actually you started from this. And a standing meditation. And then people call this $1 million secret. And then, no, we'll do this together, let me show you. And then before we get into that, I'll tell you how that helped my sleep. I met this grandmaster who is the legend of Chinese martial art back in 1982. That was my 3rd-year engineering school. And I was the champion already. So I was introduced to him. And then he said, young man, you're in your 20s. I'm 6 years old. You're the champion. I'm nothing. And let's do some pushing. Means like a Spartan. I said, okay. So we pushed, and then the moment I touched him, I knew I was dead. He was sending me flying to the bed, to the sofa. It's a small hotel room in Shanghai. I said, what is that? And then I know you're the master, but I did not expect the disparity that huge. He said, you learned the movement, but you did not learn the energy part. I said, okay, how can I do that? He said, you stand. I said, how long? He said, 2 hours. I said, you know, in China, you never ask a question, right? So the master said, you do, and I started doing it. Then 1 month into the training, and I said, master, I really enjoyed it. I saw the energy change, all the benefits you mentioned, but I have one problem. He said, what's the problem? I said, the problem is, before I met you, I'm at engineering school, I was very competitive, I developed a very severe sleep problem, insomnia. But now I have another problem. I fall asleep, I cannot wake up. And then he said, I'm sleeping 10 hours a day. I said, my school will start very soon. I cannot sleep this long. He said, don't worry about that. Because your body, your nervous system is tired. Try this. Continue practice. I promise you, 1 month later, your sleep will be back. And he was right. And then back to normal sleep, but it's a deep, deep sleep. Actually, since 1982, I started offering this for sleep. Simple, you know, and then let me show you how to get into that. Why don't we stand up? Okay, yeah, please. Very simple. You know, by the way, I'm going to send this PowerPoint to you, and so you don't have to remember, just get the idea, okay? So let's do this. Let's all face that screen as our friend. So our left foot targeting, put our feet in 90-degree angle. Our left foot is targeting the screen, and our right foot is targeting this this water. Okay. Now the protocol is 1, the back foot slide out half of the shoe length, okay. And then number 2, the left foot, which is our front, whole foot length. Number 3, turn the back foot in 30, sorry. And then number 4, the front foot turn in 3. Actually, originally it was 5, and people say, I remember, I said, I changed to 3. So it's a 30 and a 3, right? Okay, now once we get there, put 60% of your weight on the back foot. And then bend your knees slightly. Just bend your knees slightly, actually soften your joints. And then you raise your arms like this. You are hugging a big tree as you're standing there. Okay? And then you think about it, we're all standing in water. We're standing in water, and the water is moving us slowly, randomly. Just to say, hey, the water is moving us. Again, it's because you guys, most of you are, especially our young friends here, of physical therapy, it's much easier to explain to you. Here is, think about, we are turning the muscles on and off to improve the economy of movement. Does that make sense? And also for the muscles we turned on, keep that on, we're really strengthening that muscle there. And in the meantime, think you're 1 inch taller. Yeah, you see? There is, and also smile. Most important thing, really important thing. And you are hugging the tree in the water. the water want to come into the tree, you say, no, I'm pushing the water away. So what that does, again, we are activating the motor units to really pushing out, get the strength training. Does that make sense? Yes, that's good. And then for those, you say you have a patient, you want to help them with back issue there, you can have a variation, say, my hands are reaching the ceiling. My whole body is growing. Yes, in the meantime, I'm working on my balance. I'm swinging with the water. And before you have fatigue, the Chinese medicine believes no pain, just the gain. What do we do? Drop the arm completely. And planting your arm into the ground. But you're still 1 inch taller. Just have that image there. Bending the knees, soften the joints. Again, raise the arms. And pushing the water away from the tree. It's a strength training. You can probably feel the arms getting there. When you're reaching the sky there, you're working on your shoulders, right? Then drop your arms. Sit down, please. Okay? Yeah. So, this is the part, if you think, okay, I remember, I probably, it's a lot of information, I want to remember a few things. This is the number one things I recommend. You can practice, you stay in the grocery line. And I will practice on the plane, I just came back from Europe. I was just standing on the plane, and you can do this, and nobody knows what you're doing, but you'll work on your sleep, your posture, and also your balance. Softening the joints is a big thing. And also this is why one can translate, when you jump, the word, I call that a warrior jump. It's softening the joints. You think about, you land like a tiger there, the sequential landing, taking off, is extremely good for your joints as you do intensive exercise, right? Okay, then we got this, let's see, why did it stop? And then, so, and also, most of you here are scientists, and then you want to see what's the evidence. In China, you look at the elders, that's the evidence. They are stronger, they speak better, they are wiser, they're happy. But here, we need to randomize controlled trial. Okay. This is one of them, at Appalachian State University, they did one study using specifically this curriculum. They find how our college students, they sleep better, less anxiety. Okay, we'll touch the anxiety better later, but here is the first part for sleep. And then body lying down too. And then this is also good for sleep, injury prevention, because it was created as a martial art. And for martial art, any sports, and how to prevent injury, that's one thing. So let me say this, I need one volunteer say, I have a friend with bad sleep, and I can come to the front, and I'll work with you very quickly. Any of you want to come to the front? We have a yoga mat. It's a private trainer with me. Okay, so okay. Come on, we have a brave physical therapy expert and Tai Chi teacher. Thank you. Well, let's get one yoga mat. You can stand up, come to the front, and yes.
Can I ask you a question?
Yes.
On these items, does it matter when during the day and how long? You said 2 hours, but
No, I was teasing you.
2 hours. Is it best in the morning, afternoon? Does it matter?
For all the exercises you can do anytime. But the beauty of this, actually what I'm doing there is I'm creating all this online 2-3 minutes. You can spread out after sitting there 2 hours, get up and do this. Okay, good. So let's, you can come and see, get up and see what I do very quickly. Lay down on the mat. You can come, and this is one method, and then, so we do the standing, it's building up the strength there. And then but in the meantime, our Chinese philosophy always is too much good things can be bad, okay? So you are creating the pressure on the spine here. And how to balance that things, you do this one, you bring your arms to the very top, and then keep your arm on the floor. If you already got a shoulder issue, you cannot go all the way top. You can still wear, that's assuming, and then this is the max body can do, right? Okay, and then so you stay here, and then you think about, this is our energy center, based on Chinese medicine. So we're gonna send the energy from here to the fingertips and to the toes on the right side. And I'm going to touch your arm and the legs and then give you the cues. Okay? So all our friend need is close the eyes, imagine. I'm sending my energy to the toes and the fingertips. What that does is you opening as many joints as possible. So here you see blood and oxygen. In Chinese we say blood and energy. Okay? Doesn't matter what we call. Let's give it a try. I give you the cues. Ready? Let's see. Sending the energy go. To the fingertips and the toes. And then let's it go. Second trick, let's go. Yes, all you need is having an image of the blood is flowing to the fingertips and the toes. We call it 70% intention, 30% physical movement. Yeah, let's try one more time. Yes. Using breathing out. And let's go. Now, for those of you working with patients, pay attention to one thing is, don't make sure the arm is on the floor. Because that's gravity is taking care of the weight, so the person is more relaxed. Okay? And then gravity, if people with shoulder issue there, this is the maximum, even before maximum, stop here. And today she's here, if she tries this every day, probably I would say 2 months later, she can move up here. And then this big patient might take a whole year to go all the way up there, but that's worth the time. Don't push it, and then next month you want to go up there, you'll injure yourself.
And what if someone has a back problem, can't lay like that, has to...
You do any modification, yes. You have a back issue. This is also an extremely good exercise for back pain. And the back and the hip issue there. And then you can have like put something under the knees, on the back, and on neck. Anything you need moderate. But keep doing that, that's the key. Okay? And then so, thank you. We don't have the time to do everyone, but I just want to demonstrate. This is the essential components there. Okay? And also for those of you say I have sleep or friend have sleep issue there, try this one in the bed. You don't have to get up. And actually I was teaching in Europe last week, and what happened in the middle, it was just so good at policy. I was teaching this and I'm too embarrassed about it. That's the power of the line meditation there. Okay, so let's continue. Yes, so let's see. So the next one is the spiral flexibility. That's the one. So we tried this one, as far as possible there. And then this is one of the spiraling flexibility we tried. Okay, I moved that to the earlier time, so just to let everybody move. And then that's for pain. Again, you have a shoulder issue there. That's okay. You can go stop here and gradually open and open there. Okay, and then so Tai Chi form, and then people always say, oh, Tai Chi form, why? Very simple, you put a different movement together. I will do a very simple, short demo. I will stay here, and I stay here, so everybody can see me. Do a very short demo of the Tai Chi form and put together for the research package. Just a few movements. So you use the standing to really get the energy. And we call that identify ourselves with the universe. And the whole body, every single point on the skin surface, you're moving water. And then it's the weight shifting and turning the body, and you have the rotation. Huge lubricant to the joints. initiate movement from your core. And when you move, again, it's the agility. And also you want to use the motion to keep your body open. So I'm going to show you one. Again, you don't have to go this big at the very beginning, but later you can go. So it's a kick. You can get explosive energy. And then you close the energy. Then you show the gratitude. And you finish. Okay. So the thing about this it is a complex movement, but the benefit is coordination. And the way is, if we figure out, this is what I striving, to do, is figure out how to break down the complexity to a single segment, so we can start and gradually, and in the meantime we challenge our cognition. This is why they say the older you are, the smarter you become. That's why, because you are challenging your brain all the time, right? So here is the Tai Chi form, and then agility. We did actually this one. This is one of the agility exercise. Why I call it agility, which is moving your body. This actually, you look at the older elders in China, the long-time practitioners, they really move like young people. Actually, this is how it motivated the general public for public health. This is how when I reach that age, I want to look like that. So, and then balance, agility, and it's also cardio. You can know that, right? It's very quickly build up that function there. And here's another study where I was at graduate school. We did, the conclusion is, for physical therapy, and then we say it's most of the time when we have strength training, no doubt we're going to gain some strength there. But our ability to control our force does not mean we're going to increase. Sometimes it's the opposite. So what that means translate to function. For imagine our elder, one of our 90 years old, climb stairs from point A to point B. If you can train our elders, given the same strength, be more accurate to where they want to step, you reduce the falling. Does that make sense? So this is to find out the variability of force production decreased. So it's double gain. We help the elders getting stronger, in the meantime more accurate to execute their force. Okay. And this is published on gerontology, and then, so again, I'm going to email the slides, you can get that. Okay, so for the mind part, you will not believe, this is the part takes most of the energy. And when I started my practice, I thought, okay, this is the balance, the strength, it's very important. As important as is the mind part, which is all of us. Okay, maybe some of you are outliers. But it's just our daily interaction takes so much of the energy. We get good nutrition, we get exercise, but we turn around and waste our energy on so many things. Okay, let me give you one example. My host family, my first host family, and I come to America in 1993, called me 6 months ago, say, I was hospitalized 3 times. I said, for what reason? She said, high blood pressure. I said, who did that? She said, Trump. And I wouldn't tell you who I voted. It's not the issue there. Okay. But the point is why you give other people the power. That's the point. Okay. So the meditation thing is extremely important. Is, for example, for our elders, we meditate on life. Is like 4 seasons. All of us, we have to go to the winter one day. Okay? And then, so if we meditate that, there's one famous statement from Chinese philosophy. It means, in life, I serve means I help my family, community, the world. When death comes, I rest. That's one thing. Think about that. And kind of like another thing is how we keep tranquility, happiness is no expectation. Do anything, I do for nothing. I have no expectation. It's another powerful thing. Another thing is extend innate kindness is the Chinese philosophy believes we are all born with kindness. You often heard the story somebody jumped off the subway to pick somebody following the subway and get it. They don't know the person. Why they do that? That's the innate kindness. You are all in the healthcare field. Why you choose this? Because it makes you feel good. And then we all want to be happy, so the logic is when we extend our kindness, we're happy. Just that simple. The way is to figure out how to extend the kindness. And then gratitude, and then I put another thing is white crane and the ducks. Let me explain to you. So here is the picture. What that means is, let me see how to translate. It says, everything has its proper nature. Every nature has proper limitations. What that means is we cannot change other people. Let me give you an example. I was on the plane last week to Europe. Once I got on the plane, a lady was sitting in front of my seat, I said, oh, here's my seat. She said, how come? And yeah, she was very upset. And she was giving hard time to the flight attendants. And then I said, well, you know, this is my seat. And then so she moved to another seat. And when I put my luggage on top of my seat, she said, no, you cannot have that. I said, okay, you want to have it? You have it. I turned around, I put another thing. In my mind, I said, this lady has long legs. I cannot change that, okay? So here's just an example. And then we fly all the way up, we landed there, and then we try to get our luggage up, right? And I noticed she could not reach her luggage. And then she turned around, she said, I said, you want to help, right? I said, I will help you. And then I take her luggage out there. It's the Chinese say, I practice the concept. We are the citizen of the universe. This person is a kind person. Somehow she's transferring her anger toward me, toward the flight attendant. That's fine. But with that big picture, that's make everything so much easier. I can turn around and put luggage in another, cabinet. That's fine. And then but her legs that long, and then I just cannot change that. So, and it's a lot of life thing is, if we can understand that, we accept that, and then we just save so much energy. So this is the one image I really want you to remember. Going home, your husband put the toilet paper different way, say, that's fine, okay? And then you have a colleague who is driving you crazy, and then you can see that's the long legs or short legs, whatever you want to find that, okay? And then, but the thing is, you just cannot change that. And then, so caregiver, that's another thing I see. When we say extended kindness, one very important thing is, it is from Chinese philosophy, it starts in ourselves. And we talk about Irving, the figure's name, right? The lawyer was talking about the elders taking care of the son. Actually, it's a simple thing. In Chinese philosophy, we say that practice the usefulness of the useless. You see what I mean? The mother is giving too much. We say everybody understand the usefulness of the useful, but a few people understand the usefulness of uselessness. In this case, the mother has to practice being useless. She is destroying her son by giving too much, by working too hard. So it's self-care, and then that's the foundation for us to help all others. So that's the one really message I want to share with everyone is just take good care of yourself and then don't overextend and then because you are kind. Again, conclusion, aging in place and in China, we did not have the choice, which is a good thing. It forced us to rely on ourselves. And I'm sharing some of our wisdom to you is how we learn that and how can we combine the medical miracle here, the Western system, and also the wisdom from China, so to provide the optimal aging path to all of us. Okay, that's the what I want to head to. And then one thing at the hospital, we always have a last thing. If I don't do that, the patient wouldn't leave, which is dancing. Let me show you what that means. And then let me show you, see, you did this one, so we can really put this in a dance step. I want you to develop this default for balance, extremely important. So we will do very simple. One, initiate from the core, do that, do that. Okay, so you can stay there, stand up. We're going to play the music. I think our physical professor talking about, have fun there. Here's the one fun we can try. And then as the music coming, let's just try. Let me show you how to do that. Okay, so. Come on, let's get to it. Okay, everybody's the best dancer, come on.
You go, Gail. Girl, sing hallelujah. Girl, sing hallelujah. Cause I'm don't believe me, just watch. Don't believe me, just watch. Don't believe me, just
This is what we said, the music cannot go up again. The imperfection is the perfection. Okay? We're happy with anything. Let's just say any questions, guys. Sorry. Okay, half of our time is good. Any questions? No? I know it's the end of the day, you're all busy, and a question I'd be happy to address. Yes?
Have they studied, I know that 1/3 of Americans over 65 fall every year.
Okay.
Have they studied falls in China in terms of older adults?
Which I don't know. I'm out of, the country for a long time, very busy here. Overall, I think even the study here, there's a bigger gap between the knowledge and our researchers need to know what is the essential training. Our traditional teachers need to learn and what is the science behind that. And we find many good studies on what JAMA and all these wonderful publications there. It's great, but I think the potential is huge. Because the curriculum I just shared with you, these several simple things, I don't think is in the curriculum published. So, and then we're busy here, China is busy as well. We always try to figure out how I use the minimum effort to get the best results. How I spend 3 minutes, 5 minutes to improve my sleep. That's something. Okay? Any other questions? Great. No? Great. Thank you for coming. Things like I teach workshops around the country, like next one coming up is in November at Kopalo. That's the biggest yoga center. And we always run one of the biggest classrooms there. Why? Because simple energy and also injury prevention. The title is chronic pain, but it applies to sleep and all these things related. and then again, in note, I will give me several days, and then I will send you a follow-up note as well, just in case you have friends with sleep and issues. That can be a very good weekend course there. Okay. Yeah. Again, thank you, everyone.
And now, will close the proceedings for us.
Hi, everybody. I'm Rob. I'm the dean, and it's a real privilege to see so many energetic people. I had many misconceptions, it seems, about fact. I had no idea there was so much physical ability in this group. We've clearly been holding out on us. So we're going to program a lot more things for our faculty from now on, carrying the dean upstairs and things like that. So this is really great. Well, there was certainly no aging in place going on in this room this afternoon, and really appreciate everybody being here, sharing your rainy afternoon with us. One thing we deans can judge well is body language. When I walked in here, I saw how absorbed everybody was, and really how much fun you were having with Master Yan. So thank you again. Let's show a warm New York Medical College applause of appreciation for Master Yan. And of course, we could not close without thanking our speakers, Deidre Locke, Janet Delott, Nikki Goronsky, Gail Lavender, Karen Kopinski, Louise Rakelmi, and our keynote, Master Yan. The advisory board, Michael Majak, Susan Fox, Melissa Lang, Annette Schulfein, and Carol Levine. We really appreciate your support for this and other events like it. I'm happy to say that this coming spring semester, which always confused me because I didn't come here as an academic, spring apparently starts in January. I had no idea. But I guess that's, when you have a PhD, you can figure that out. All I can say is, in the next semester, between January and May, we will have another colloquium along these lines as part of the Center for Long-Term Care. And we hope you'll enjoy that one as well, which will come up, as I said, after January. And also a year from now, in the fall of 2019, we'll be doing this. So please keep reading your emails. Whenever you see something from Dr. Knapp, respond right away, because he really runs an outstanding center. We're very proud of the center, and thanks so much for being here. It's a privilege to be here. Watch out for the slippery pavement out there. It's a bit slippery. Everybody going home, Godspeed, and don't speed. Thanks very much.